You're listening to the Assembly on Sleep and Respiratory Neurobiology podcast, brought to you by the American Thoracic Society.
Welcome, everyone. I'm Brandon Nokes. I'm the director of hypoglossal nerve stimulation at VA San Diego and an assistant professor at UCSD. Today, for our Sleep Pioneers podcast, we're lucky enough to have Dr. Rapoport here. David Rapoport is a pioneer in the field of sleep medicine, and he's a professor of pulmonology at Icahn School of Medicine and the director of sleep medicine research. Thank you for being here, Dr. Rapoport.
My pleasure.
So just to get started, can you tell us a little bit about your background and education?
Sure. So I came to medicine through a somewhat circuitous route. I started out actually being involved in theoretical physics, and in the spirit of the late '60s, early '70s, I was looking for social relevance and felt that I was not getting that, although I enjoyed what I was doing. And so I switched to medical school, where I had intended to become a pure clinician and get into, what was sort of the barefoot doctor idea of going to where the need was greatest. And that lasted for about 10 years while I did my training in pulmonary medicine and so on. And then in my first rotation of my pulmonary fellowship, I had an extraordinary sort of aha moment where I went to my first conference during the first week of my first rotation, which was the Pulmonary Function Laboratory. And I met the person who turned out to be probably my mentor for the next 35 years, Roberta Goldring, who was a big proponent of physiology in everyday clinical practice. And her major contention was that there really was no difference, except the way you labeled it, between clinical practice of medicine, if you thought physiologically, and living, the NIH grant-supported route of doing funded research. And in our first conference, we reviewed some PFTs and got into in-depth thinking, which reawoke all of my interest in physiology and some background that I had in computer science and so on. Got interested in exercise and a variety of other things that brought me fully back into the field of doing physiological work in a clinical setting. Questions come from the patients, but you then assess them physiologically and try and figure out what's wrong and why, rather than just focusing on trying to make people better. The two are not mutually exclusive by any means. And shortly after that, so after I finished my pulmonary fellowship, sleep kind of reared its head. Roberta's area of interest was hypoventilation, and she had been involved in a lot of the early work in hypoventilation syndrome and its treatment with external non-invasive ventilation. And it was just becoming apparent that obesity hypoventilation syndrome, which was this extraordinarily rare experiment of nature that fascinated pulmonary physiologists who were interested in control of breathing, which she was in the midst of, that had a sleep component and that there was something funny going on. The general thinking prior to the period in the late '60s was that these patients retained CO2, and that's what made them sleepy. Nobody thought of looking at sleep. They just said, well, they don't breathe and they're sleepy because of their high CO2. And a group of people, among whom Christian Guilleminault was probably prominent, started looking at patient sleep and started seeing sleep apnea. And there was this period of time, which actually has persisted in large amount, where hypoventilation and its worsening during sleep and sleep apnea, which is the intermittent upper airway obstruction, which in some cases is associated with hypercapnia, the two were kind of confused, and it was thought that there was a spectrum there. In my mind, they're two totally different phenomena, not necessarily different diseases, because they both occur in obesity. But one is a disorder of the brain just not wanting to breathe enough to sustain it during sleep and during waking to some extent. So the sleep is an exaggeration of what's happening all the time. as opposed to sleep apnea, which is a disease that occurs only in sleep and which has to do primarily with the upper airway and which in general does not produce hypercapnia. Anyhow, those are the things that we sort of got involved in. There was no sleep lab, there was no sleep expertise for doing respiratory measurement. So basically, my early career was spent in jury rigging EFT laboratory during sleep, which is sort of where monitoring came from. And it was fascinating. It was a lot of fun because nobody knew anything at that point about sleep. And so it didn't take very long to get to the cutting edge. I mean, literally, all you had to do was stay up at night and look at it, and you learned something. And it was a lot of fun and very very rewarding.
That's great. And I mean, it gets kind of got into my next question of how you get involved in sleep medicine. And you mentioned Roberta Goldring. Who else helped mentor or inspire you as you got started?
Well, I was extremely lucky. I mean, it was a small field. There were people who were interested in control of breathing, and they were the gods of the literature. And Elliot Phillipson was one of them. And I was lucky enough to present an abstract, which probably wouldn't get on the program nowadays. It was three patients, each of whom did something different, but I somehow managed to do a talk about that as one of the abstract presentations following Elliot Phillipson's talk about sort of the early views on sleep disordered breathing. And so I got to meet him and talk to him, and I was very excited just to be in the presence of such an important figure in control of breathing. He's one of the people, for those who don't know, who very early on got into sleep from the area of control of breathing against all of his mentors' advice. I mean, they basically told him, "What are you wasting your time looking at sleep for?" And he did some of those phenomenal experiments with dogs who were given sleep apnea and then studied and wrote some of the very early and pivotal literature describing sleep disordered breathing as a disorder which was partially of control in addition to being the upper airway. And he complemented sort of the neurological input that people like Christian Guilleminault and so on. The other thing that was very important for me was a conference I was lucky enough to go to where it was one of the very first sleep and breathing symposia, which was held in Banff, and where literally everybody in the field was, all the big shots, all 50 or 60 of them who were studying this were. And then there were a few junior people because the concept of the meeting was that every senior person brought a junior person, and where I got to interact for 4 or 5 days in a very informal, friendly, and small group environment with literally all the luminaries of sleep. So that was pretty exciting. And what was nice for me was that this built unexpectedly on my background in physics and some engineering concepts and computer knowledge that I had, which I had acquired totally by coincidence because it didn't seem to have any relevance to anything I was doing, but which turned out to be very important. And I brought to sleep what people in the exercise physiology world were sort of learning, because Carl Wasserman had just introduced the idea of breath by breath analysis using computers to CPETs and exercise. And what we now do as a CPET was sort of introduced by that. And that approach was sort of one of my other interests, which was in the pulmonary function lab with Roberta's input. I basically reproduced some of the CPET technology using my sort of very simple computer approaches, but that was fairly sort of unconventional back in the mid 70s when I was doing this, late 70s and early 80s, before computers became common. And when we brought that to the sleep lab, that was right at the period when we were moving from the GRASS polygraph and paper tracings and so on. I remember long, endless discussions with my collaborators about how can you read a sleep study on a computer screen? I mean, you got to have the paper. You gotta see it. And I was trying to convince them that there were certain advantages to recording it digitally and being able to manipulate it offline. Because in the paper days, if you wanted to get something where you saw two views, one the EEG view at rapid speed, the breathing was really hard to detect big patterns on. You could see apneas, but you couldn't see chain Stokes. You couldn't see all the things that we see by compressing the screen. And so when you wanted to do something, you had to be thinking ahead to what the illustration was going to be in your paper and change the speed of your paper in anticipation because you couldn't do it afterwards. And when computers became available to record things digitally and you could change the speed, change the display, look at things, boy, that was like just turning on a light bulb in a dark room. It was really fascinating, and it led to a lot of other things, little simple things like that. Um,
That,
there were a lot of other people that I was lucky enough to cross paths with. So other major event in my life was the fact that I was doing some respiratory failure work in the ICU, and so I was very much involved in ventilators and treating patients who had various issues, and we spent a lot of our time talking about ventilation. And then along came this crazy Australian who said you could strap a mask on somebody's face and cure sleep apnea. And the paper in 81 that Colin Sullivan published was presented in a state-of-the-art review by the then editor of chief of Chest, um, Jay Block. And he had a very amusing way of presenting this, and he presented it in just that spirit. And I was sitting in the back of the room with the respiratory therapist I work with, and it just clicked. And we said, this is it. This has got to be the right way to treat sleep apnea. We went back home, and I published what was then my first author publication, which was a rather short paper about the reversal of hypercapnia, but it got into the New England Journal. And so that was a rather sort of strong encouragement to do it. And it led me to the treatment, having just relatively recently before that gotten into sleep, the treatment of what turned out to be a very common disease. We didn't know sleep apnea was common in those days. We thought it was a very rare thing that only affected a tiny number of very obese patients and was of relatively little clinical interest because there were no people who had it. And there was no treatment for it except tracheostomy, which was not very attractive to most of the patients. We were doing them. I remember, being involved in 10 tracheostomies in the early days, which were very interesting to me because they were similar to ICU medicine done in the home. And that was an interesting experience also. So those features all combined to make it fun to treat the patients, and they got better. That was the other part of it that was great. I mean, they were very grateful, very devoted patients who I followed for a long time in the early days.
that's great. I mean, I think a lot of good stuff there. But amidst all of that, what of your achievements are you the most proud?
Well, I have to say that Roberta taught me this idea of constantly looking at, in her case, it was PFTs, and rapidly that extended now into sleep, and saying, why the devil is this happening? And asking that question and answering it. And frankly, I think that has probably motivated most of the interest I have in my, come to work every day, which is that Mother Nature offers us fascinating things. And if all you're interested in is making them go away, which, kind of is what you do in a lot of medicine, and not worrying about why it's working, it gets pretty quickly boring unless you get some sort of peripheral reward from the human interaction, which I don't want to downplay in any way. I think pediatricians are probably, the most salient example of that. They just really enjoy working with kids. And relatively few of them are confronted with things that need a lot of physiological investigation. There's subsets where that's not true. But when you're treating upper respiratory infections and croup and little things like that, that's not where you get your pleasure. You get your pleasure from interacting with the kids and their mothers and their fathers occasionally, and making them better, as opposed to the physiological approach where we deal with something which is fundamentally a mechanical problem, sleep apnea and control of breathing abnormalities, where you get a lot of pleasure from making people better, yes. And it's fun to talk to patients, but you also get a lot of pleasure, at least in my case, from saying, why is this happening? What can I learn from it? This is an N of one experiment that Mother Nature has thrown my way. What can I learn from it? So, in coming back to your question, I think the thing I'm most proud of is the fact that I was able to do that. And in a few cases, actually get some answers, which is relatively rare in established fields and relatively easy in new fields, which sleep was in those days, at least the respiratory side of it. And so things like being able to monitor better than we were doing, moving from thermistors to the nasal cannula, which was one of the things that I accomplished early in my career. It didn't even occur to me that that was something new. I was just thinking of how can I get a pulmonary function lab on my patient when they're, when they're sleeping, and the thermistor just wasn't providing the kind of information I wanted. It was sort of too much of an all or none and subjective thing. Although it was very instrumental in advancing the field, I wanted something that was a pneumatac, and you couldn't put a pneumatac except in research studies. And the nasal cannula sort of evolved over several years as a crude pneumatac, which to this day I think gives us a lot of information we didn't have in the early days of sleep work. The other thing that got involved in was CPAP. And although I don't think I contributed a whole heck of a lot except doing a lot of CPAP and using it as a research tool, and then eventually morphing it into a clinical kind of a thing, it it allowed me to ask a lot of interesting questions. And one of the fun games we used to play in the morning when we read the sleep studies with the fellows was, you know, what can you do to keep us from falling asleep ourselves, looking at, study after study that looks the same? And so we used to play little games about, what you could do in the morning read, which to me was one of the very fun things where both I learned a lot, but I also was able to teach sleep apnea related stuff to pulmonary fellows who would rotate through. And one of the games we played was, can you tell when the patient woke up without looking at the breathing signal? And that little game turned into a very interesting series of observations, which, on the one hand, helped us with understanding the relationship between arousal and breathing, which to this day remains a very peculiar and understudied, I think, a thing, but also focused us on changes that happen in breathing that you can see in various signals. And the flattening, which we now call flow limitation or inspiratory flow limitation, some people prefer to call it, and which not everybody agrees is the real definition. So some people call inspiratory flow limitation a reduction in flow, which is what the name implies. We've always used the term in my sphere of saying it's a change in shape of the inspiratory contour. And that shape turned out to be so incredibly recognizable in obstructive sleep apnea that once you saw it, it was hard to believe that you hadn't been focusing on it all along. Of course, thermistors don't show it. And if you put the kind of filters you put on thermistors when you switch to a nasal cannula, you don't see it either because it's all averaged out and you kind of miss it all. But if you look at the raw tracing of a pneumatac and to sort of 90% of an inspiratory of a nasal cannula, you see that same change in shape. And that change in shape has a huge theoretical basis when you start reading about Starling resistors. And we made some in the lab to just document that. It became sort of a hallmark of the disease and of the obstruction that was occurring. And it led to the concept of auto CPAP. Because if you could recognize it, you could take advantage of it. And you could use that as an endpoint for titrating CPAP. So that was the other thing I got involved in very early and proposed some ideas which are now kind of standard practice in CPAP. So I would say that the combination of those things, just sort of recognizing that monitoring was important and using the monitoring for various practical applications has always been the way I've worked. And I've been lucky enough to have great commercial, kind of collaborations, which exploited that because most of these things were, interesting physiological research experiments, but not really of any great use until you could find a commercial partner who was willing to take it and run with it. And I think that's what's not just in my own work, but in many people's work. That's what's put the field of sleep forward, is the fact that ideas began in what was sort of a niche sort of Rube Goldberg research laboratory and were taken over and put into the commercial application and then delivered to large numbers of patients, which we were lucky enough to have with this disease. And that's really where the knowledge came from. And that's what put sleep on the where it is now as a nearly separate field.
I'll have to avoid my enthusiasm and urge to ask about how the auto CPAP algorithm might be influenced by like negative effort dependence, but
Well, I think you're following in the tradition. You're looking at the signal and saying, what is it telling me? And I think there are many ways to do that, and that's very, very important.
thank you. So the next question I have is what brings you the most joy professionally?
Well, as may already be apparent, I get a kick out of having fun. And so for me, taking care of patients, which is a very satisfying kind of a thing, and interacting with them and trying to translate their questions about why they're not feeling well into something that I understand and therefore can treat in many cases is very satisfying. And I think that's what keeps me going. And the great thing about it is when you're able to put in, into that process the issue of extracting information from very limited data. I think that's been one of the most fun things in the sleep world is that we have all of these signals and all of these tracings and all of these things we do to the signals, which produce a wealth of information. Unfortunately, we throw away most of it when we try and summarize it. And while it has worked fairly well, the AHI is sort of the metric that best captured the disease as it was sort of becoming recognized that sleep apnea was a disease and its treatment. And a lot of the epidemiology was all based on this very, very distilled amount of information when you have this wealth of stuff. It's kind of like, if you looked at the EEG and all you were interested in whether somebody was awake or asleep, you could probably get that out of the chin EMG and not much else. And throwing away all of the things that we've now learned about sleep structure and about REM sleep and about spindle density and its reflection in cognition, all these other things which require that you look at the signal and not be fooled into thinking that everything can be tabulated into one number. The respiratory signal has suffered from the fact that the AHI was so powerful and it was so useful in advancing the field to recognize it. But unfortunately, there's a lot more buried in it. And I think that's really where we're now facing to anticipate one of the other questions that we've talked about what is the challenge to the field. I would say, to my mind, that's one of the major challenges I see coming. Because on the one hand, we have very powerful mathematical tools, AI, and looking at multiple pieces of information as a black box to see if they give us the answer without understanding exactly why. And we have the proliferation of signals, which is happening with the home monitoring devices, which are now moving towards very, very far removed from breathing. The things like the Aura ring and other types of things which look at the pulse transit time and the PPG and a variety of other things and use associations to tell us about what we think we want to know, which is what's the AHI and how is it responding to treatment and maybe a little bit more derived, is it telling us about the sympathetic nervous system? But it isn't breathing. So we have this huge pressure to move into simple, tolerable tools that are giving us a wealth of new information that we can't quite relate to what we know traditionally about breathing, but which have associations, and which AI allows us to compound into a useful metric, if by useful you define what we already know being measured more easily. On the other hand, we have this incredible wealth of knowledge that has accumulated over the years. My own personal interest, of course, is the respiratory signal, which we are tempted to give up because of the ease of acquiring all these others and the patient acceptability. And so, at the very time when we're beginning to exploit the applications of advanced mathematics, signal processing, and the things that are possible on the respiratory signal, what you just referred to, negative effort dependence as opposed to just frequency and tidal volume from the respiratory signal. Um, these are very insightful bits of information where we're extracting more from the signal. And so that's competing. On the one hand, we have more from the signals we have, and on the other hand, we have less signals, more huge volumes of data where we can extract from that sort of trends and associations and so on, which are clinically useful. And so I see the field of sleep being torn in these two opposing directions. On the one hand, we have big data. We want thousands and thousands of sleep studies. On the other hand, we want the next version of auto CPAP or flow limitation or of negative effort dependence telling us where the airway is obstructed. All of those things require the respiratory signal, which we are tempted to give up. And I don't mean to suggest that only the respiratory signal, that applies to the EEG, which we are giving up when we do home sleep testing for apnea. A lot of other versions of this same dilemma, more is less and less is more, are competing.
That's great. Thank you. And do you think there's anything you would have done differently with your career?
Well, there's always, things that you regret. Luckily, I don't have too many, and frankly, I'm still having fun, close to 50 years into it. So no, I mean, it's probably presumptuous to say no, there's nothing I would change. Uh, but there's enough that has been positive for me and lucky that I'm pretty satisfied with where it's taken me. Um, I've, as I said before, I've had a lot of fun. I get a lot of pleasure out of making patients better, and I get greatest pleasure out of talking to young people and watching them develop, and trying to light the fire of asking that big question, why? Why is this happening? And to me, it's a great deal of satisfaction, which I get, which I still get now, and which I wouldn't change for the world, of being able to interact with people who come to me. They're bright, they're well trained, they're good clinicians, they're sometimes very knowledgeable statisticians and researchers, but they haven't quite focused their attention on the why question. And if I can light that fire, I get a lot of pleasure out of it.
That's awesome. And what advice would you give to people who are just getting started in the field?
Well, again, I think these are very turbulent and tough times, and we don't have to go into politics to say that this is a very challenging time for a young person trying to make a career. Those of us who are established probably aren't going to feel as much pain as those who might be turned away because it's becoming very, very hard to function with the cutbacks that are going to be forced on research endeavors and things like that. So you know, perseverance. I was told a long time ago, if you don't get your first grant, you apply for it again and again and again and again until you get it. And the people who are not perseverant, some of them are lucky, and some of them drop out of the field. I think that's going to remain true, and I think that you have to enjoy what you're doing to be persevering. So I'll come back to that theme that you need to find a niche where what you do satisfies your needs, but also moves the field forward. And sometimes that involves getting a better measurement to the nth decimal place of something that's already known. Sometimes it involves recognizing where everybody else has not looked. And so I urge people to find a corner of whatever field they go into. I hope some of them will be in sleep and in respiratory physiology. Find a corner that hasn't been fully explored and find something about it that excites you and hopefully isn't so narrow that you'll only see one case in your lifetime. Um, and then when you identify that, look at every patient for the maximum you can get for them. Every patient is an N of one experiment that Mother Nature has thrown your way. And the skill that you have to develop is being able to recognize what's new about it, what's not explained. Another lesson that Roberta taught me often was you can often gain a lot of expertise and advance your own career by asking the opposite of the question of, why is this happening? And instead ask the question, why is it not happening? Why is it that 9 out of 10 patients have this behavior, but there's that 1 out of 10 that's not doing what they're supposed to? Focus on that patient or that situation, and you will often get an answer to why the other 9 are doing what they're doing, and advance the field and your own knowledge. So my advice to people is, if you are going into this research world, expect to fail a lot and find a way to have fun and get pleasure out of it, whether or not you become, a candidate for a Nobel Prize. Persevere. Look for examples of things that other people haven't explained, and most importantly, look for the exceptions, because they often teach us what you will miss if you look at everybody who's doing the right thing.
This was wonderful. I really appreciate you taking the time to talk to me, and this is great. And thank you so much.
Okay, my pleasure.
Thank you for joining us today. To learn more, visit our website at thoracic.org. Find more podcasts from the ATS assemblies on YouTube. Don't forget to like, comment, and subscribe so you never miss a show.